It's a pleasure for me. We're about 5 minutes ahead of time, but this is a better place to be than to be 10 minutes behind. So it's a pleasure for me to introduce our second presentation, which comes from Dr. Amy Bohnert. She was referred to earlier. Dr. Bohnert is an associate professor at the University of Michigan Department of Psychiatry and a leading investigator for the Center of Clinical Management Disease for the Department of Veterans Affairs. The research focuses on mental health and opioid use and misuse. And Dr. Bohnert will share with us information about the ongoing prompt mental health study part of Precision Health. Again, as questions come to mind, please post them in the Q&A, and then we'll address them at the end of Dr. Bohnert's presentation. Amy?
Great, thank you. And just a correction that my primary affiliation is the Department of Anesthesiology. Tina and Rachel, do I start sharing my slides?
They're already shared, Amy, or do you prefer to share them yourself, Tina?
Oh, it's just, do I have control? I couldn't tell.
If you want full control, it's better probably for you to share.
Okay. I'm struggling a little bit with the settings. Would it be easier? And Tina, I know you had added to them as well. Do you mind pulling it back up, and maybe I'll just say when to advance? Is that the best strategy? Thank you. So next slide. So I'm going to talk about the prompt, which is providing mental health precision treatment. This is the mental health use case, of the Precision Health program. So this was one of these projects where we got to take an important topic that was decided on by the leadership as a priority and design a project to address the key problems of precision health within that area as best as we could. So the principal investigators of the project are myself and Srijan Sen in psychiatry and MNI, and we have collaborators across lots of different departments and programs in the university. Next slide. I want to start by talking about what mental health treatment looks like today and what we think a precision health approach could do to make it look like in the future. So a vision for the future. What we do today is often that we ask participants, or patients rather, when they get into a clinic, to tell us about their symptoms over long periods of time based entirely on recall. Our care tends to be episodic. We lack objective measures. It's very clinic-based, so there's not a lot of care that occurs outside of coming into the clinic. And as a result of all of those factors, it's extremely effortful. We do not have nearly enough mental health providers in this country. And as a result, there were really long wait times to be seen. And all of that, on top of all of that, we don't have good systems of matching patients to specific treatments. So there are many different treatments for mental health. There's lots and lots of different types of medications. There's lots of different types of psychotherapies. There are also some interventions as well. And at this point, there's basically a stepped care process that each patient gets regardless of their current severity, oftentimes, and based on the medications that the particular doctor they get happens to refer. What we need care to look like is objective measures of how someone's doing in terms of their mental health. We need those measures to be continuous, not just asking someone what was the last 2 weeks like. We need it to be ubiquitous. We need it to be as effortless as possible in terms of being automatic measurement. We need that data to have immediate access, and then we need a way of matching patients to treatments. And this isn't just our team's view. This text itself was adapted from a perspective piece written by Tom Insel, who is the former director of the National Institute of Mental Health. Next slide. In terms of describing the project, I'm going to start a little bit with study design. I'll talk about how our enrollment's been going. And then I'm going to present 2 types of preliminary findings we've had in our data so far, because this is a study that's ongoing. I'll talk a little bit about some treatment effects of mobile interventions we've been looking at. And then very exciting, I'm going to talk about some initial findings around precision matching of patients to treatments. Our project goals are twofold, and this really has both a research goal and a clinical goal. So our clinical goal is to increase treatment capacity through using mobile health in the outpatient psychiatry services. Our research goal is to accelerate recovery by matching treatments to patients. The sites that we're recruiting from for this study are the University Health Service, which primarily serves students, and then also outpatient psychiatry. And we've more recently been able to pull in people who are getting primary care from, mental health care from primary care as well. We try and recruit people when they're at least 2 weeks ahead of their scheduled first appointment. This generally people are on the wait list for about 10 months before they get into care and scheduled about 6 weeks out. So we have a nice window here to be able to get a baseline on people before they even start treatment. And during that period, they're randomized to one of a couple different types of mobile interventions that they receive via their phone. And I'll talk about what those are in a couple slides later. They also receive a wearable sensor. So they receive a Fitbit from the study, or they can use their own. And then we observe them for a couple weeks. They have their first appointment. And then after that point, we consider it an observational study where the study itself doesn't control what treatments they get, but we're able to measure what types of psychotherapy they get, what types of medications they get, and continue to study and look at how their survey responses, how their sensor data is different based on what treatments they got. Next slide. This is a different way of presenting the study design more from the participant's point of view. So what would this look like as a participant, or for those of you who are on this, who were participants? So we identify people while they're waiting for care. We then recruit them by email and phone contact. They get onboarded with some support from the study staff and with our study website for the mobile app. They receive their Fitbit shortly after that as well, and then continue to complete surveys for 6 to 12 months, depending on the specific protocol. During that period, they do follow-up surveys and submit daily assessments of their mood on each day. So they get a question of how is your mood today on a 0 to 10 scale. And then they also have clinic appointments in that time. Next slide. So as I mentioned, they receive a Fitbit from the study team, and this is just a standard off the shelf. This is actually an interesting area of research where there's a lot of different opinions. There's a lot of research using much clunkier technology that at an individual level is more accurate than a Fitbit, but isn't very scalable. People don't want to wear them for very long. They tend to be for very short studies and very small studies because they're so expensive. So we made the choice to go with Fitbits that can really be integrated into daily life very well, and where people get their own data as they're participating in the study through the Fitbit app. Next slide. I mentioned that people get randomized to app-based interventions. So far, we've been using 2 primary interventions, although we're hoping to continue to consider and test new things. For a mindfulness app, we've been using an app called Headspace, which is commercially available, had some good prior data on its effectiveness. And then for cognitive behavioral therapy, we've been using an app called Silver Cloud. Also, among the many apps that do CBT, this had particularly good data from other studies on effectiveness, and has modules. And for both of these, we give tracks to participants based on whether they're higher on anxiety symptoms versus depressive symptoms. Next slide. On top of that, we also have a study app that was built specifically for this study. So this app collects all of the data. This is where we do the assessments, including those daily mood scores. But we also have developed enhanced feedback that gives that personal data back to participants in ways that can hopefully help them with managing their mental health symptoms. So you can see in the first picture here, there's a screenshot of an iPhone looking in the app. And this provides a summary dashboard of someone's sleep, steps, how many minutes they used one of the apps. At each level of days in terms of categorizing days by their mood. So you can see the top row there is what was those behavioral measures like from their Fitbit on days where their mood was really good. And that's divided into tertiles. You can also see there, it gives a day-by-day data as well on those same metrics of sleep and activity and mood. And then the app also gives notifications that are personalized based on information and meant to be motivational to improve sleep and give suggestions for improving activity and managing mood as well. Next slide. So with all these, this is a little bit complex in terms of our randomization, but we have primarily 3 groups where, but really there's some subgroups within it, but there's a group that gets just that enhanced feedback. So in some ways that's kind of our control condition, although this is really an enhanced usual care because they're getting more than standard care by getting that Fitbit based enhanced feedback. There's groups that get one of the 2 apps. So they're randomized to either the CBT app of Silver Cloud or the mindfulness app of Headspace. And they get just that, although they will be wearing a Fitbit, they don't get the enhanced feedback from it. And then there's a third group that again gets one of those 2 apps of Headspace or Silver Cloud, plus gets the enhanced feedback. So we randomized to 3 groups, and then within 2 of those groups, there's a secondary randomization. Next slide. So now I'm going to transition to talking a little bit about how enrollment's going. This report is as of 2 days ago on Monday. We were up to 1,853 participants. The gender distribution in this study looks pretty similar to mental health patients overall, where it's about over 2/3 women. In terms of what phone people are bringing themselves into the study, about 2/3 also use an Apple or an iPhone, and about 1/3 using an Android. And then people also have the option of doing it online. Next slide. We've been really edified by the engagement on this study. So many studies, and we're asking a lot of people in terms of completing surveys, but we have really, really high completion rates. At the 6-week survey, 92% of people have completed that survey. The daily mood scores in particular, I've done other studies with these type of daily assessments where you ask people to answer a single question every day. And usually in these studies, you're doing great if you get 50% of those assessments completed. But with this study, we've been consistently above 80%. I think it helps that we're asking people about something that they're concerned about, and that they can potentially later take that data to their clinician to help measure how their mental health has been more in the moment rather than asking them to recall. We also find that there's high engagement in terms of people using the apps that they are assigned to. So we were able to look at this more closely with the Headspace, which is the mindfulness app. And on average, people had 15 minutes a week of usage if they were randomized to that arm in this study. Next slide. Another exciting thing we found is just with these very low cost mobile interventions for that period while people are still on the wait list and haven't yet started care, we're seeing some symptom decreases. So some encouraging sign that the mental health apps can be a bridge to care or bridge and treatment while people are waiting for care. We don't think this is what's just called regression to the mean, because people have already, which is the idea that if you recruit people into a study when their symptoms are particularly high, in this case, if we recruited them when they first started seeking care, you might expect to see some of that regression to the mean. Instead, because people are assessed first when they're at the point of getting scheduled, they've already been waiting for care for a while, and we think the regression would have happened at that point. So what these symptoms are, the green line, the PHQ, is a depression measure. So quite significant decreases there. The blue line is the generalized anxiety disorder scale. So again, not quite as remarkable change, but still some change. The third one, the assist, is a global substance abuse measure. Unfortunately, that's been harder to move with these apps, although perhaps the apps are more geared towards addressing mood and affect, and that's not entirely surprising. Next slide. I mentioned that we have some promising signs of effects of our interventions beyond just those global decreases looking at specific interventions. So this particular analysis, we looked at how people's weekly steps changed based on whether they were in the group that got, one of the groups that got the tailored feedback, which is from the study app, or whether they were in one of the groups that did not get that tailored feedback. And what we see is that the people who were in the tailored feedback had consistently higher steps than people who did not get it. And as a reminder, that feedback did include information about how to increase your activity and included tailored feedback based on what their activity had been in the past days and weeks. Some of the drop off you see here in the none group is, I think sometimes in these studies, people get a Fitbit, they get excited in the beginning, it increases their activity. But like all of us, when we have those plans to be more active, it's hard to sustain. So I think the none group with the feedback, that slight decrease is somewhat expected in this type of data, but encouraging signs that the tailored feedback intervention on top of it can help overcome that tendency to lose some of the excitement of the Fitbit and the encouragement and the feedback from it, and actually continue to see increases. Next slide. Next, I'm going to get into data on some new directions that we're looking at with precision matching. So this one's just a preliminary analysis looking at one particular measure, but getting at the idea of, can we detect from just the passive measures that comes from a Fitbit when someone is getting better? So to do that, for this particular analysis, we took people's baseline PHQ, which is their baseline depression score, and we took their PHQ score, so again, their depression symptom level at 6 weeks, and classified people whether their change in symptoms during that time met what, by the standards of that measure, is considered remission from depression or not. So who gets better enough in those 6 months, those 6 weeks, to say that they've significantly improved and actually are in remission from their depression. We then classified people on their change in depression symptoms during that same time. So I put somewhat of a wrong title on here where I said predicting remission. It's really more of a detecting remission because it's, are there things that we can measure passively that tell us and can tell us faster without having to wait till your clinic visit on how your mental health symptoms have changed. What we found is that people who had a change in steps that was above the 50th percentile were more likely to achieve remission than those who were below. And you can see that difference is not quite a 10% difference, which I think, considering what the outcome is and considering we're looking at just one measure, is really exciting. We're looking to add more measures to this as we go, as well as the next analysis I'm going to talk about on the next slide, which is getting at the idea of matching instead. So for this, we took those Fitbit-based measures for a baseline period, so before they were getting treatments, and classified people based on both their steps and their sleep this time. So I recognize that it's a little bit busy there, but the first group, to focus in on that one, because that's where there's some particularly interesting findings. Those are people who in that baseline period had both low steps and low sleep. So those are people who are not sleeping well, not very active, and having a lot of probably somatic symptoms of their mental health problems. Then we look at, among people who were in that group, those who were randomly assigned to CBT and those who were randomly assigned to the mindfulness intervention, how many in each of those two subgroups achieved remission. And in that low group in particular, low steps, low sleep, we actually see pretty substantial evidence that people there in that group would be much better off getting mindfulness than CBT. So you can see on the whole, they had less remission than the other groups, which I think makes sense when you think of what that group represents, but they had pretty similar outcomes if they got mindfulness and significantly worse outcomes if they got CBT. So for that group, if we had that kind of data on people, we could say, you really should be getting mindfulness at least first until we get you to a place where we can decide what's next. So then with the other groups, less remarkable information to tell you about precision matching, although a little bit of a hint that perhaps as we collect more data in the last group, the high sleeps, the high step, that maybe actually CBT would be more effective for that group. Next slide. Following up on those findings, the precision matching direction, we're really excited that we just got awarded an NIMH R01 2 weeks ago. So got awarded a full-scale study from NIMH to dig deeper on that question specifically. So how can we find lots of different markers that could help us understand when someone is getting better and be able to passively detect that from their data, and how to match them to the best treatment for that person. For this next study, we're going to focus on what's labeled as phase 2 here. So look more at medications and counseling and try and inform the decisions that could be made in clinic. We're going to look at a bunch of different measures. We've been starting to build some new partnerships to add some more novel measures that you can get from Fitbits and from phones that have been in some small piecemeal studies, one by one, shown to be promising, but hoping we can bring that all together to bear in an algorithm type approach that would really match people to the treatment, shorten their time to recovery, and then by doing that, reduce wait times and make sure that more people get served for the mental health care they need when they need it. I believe that is my last slide, but I'll let Tina confirm. Looks like we're not moving, so yes. So I am happy to take questions at this time.
Sounds good. Thank you very much, Dr. Bohnert. This was very exciting. We do have a couple of questions, and we invite more. The first question, and incidentally, they're both from prompt study participants. The first question asks, my study participation is up to a year. Is it possible the study might later on end up being extended beyond the first year, is what Anne, the participant, asks.
We don't have plans to do that at this point, but it's an interesting question that I will bring back to the team for us to consider whether there's a way we could, if people are interested, continue to collect data, especially the passive data.
Okay. And the second question from a different participant is asking about life events and comorbidities. There was no way, they say, for me to record non-U of M CBT therapy. I was not able to report major life events, specifically pregnancy, birth, and so forth, which might affect physical activity, sleep, mental health, and more broadly, health. Are you accounting for those expected or unexpected life events as you conduct these studies, and how confident are you in the results and the conclusions? I suspect the meaning is if you don't account for some of these sporadic outside effects. Very interesting question, thought-provoking. Yeah.
That's a great question. Yeah, and I really appreciate that we're getting feedback from people who are participating in the study. So I think these are great ideas, especially with the new study where we're going to be focusing more on in-clinic treatments. I think we should be able to get medications from outside of the system because of the way the Precision Health program as a whole gets SureScripts medications, which are from electronic prescriptions and would include ones outside of things that are written or filled at U of M. But this is a great point that the therapy, there's not a similar type of system. So I think we should definitely add that. And the life events is a really good question too. I actually suspect that so maybe there's two things. Some of those life events, like specifically the example of pregnancy and birth, we would be able to have from medical records, right? Because this is linked to at least the U of M medical records. I actually suspect that the health app probably knows whether you're pregnant as well, and we get data from the health app. But there are other life events that I think would be good to start measuring, and there is a good measure for that we've used in some other studies. So I appreciate that, and thank you. Oh, and I think there was a third part. How confident are we in our results and conclusions? There's an interesting kind of, maybe this isn't quite what you meant, but to be a big picture question there, I touched on a little bit with the Fitbit, where there's folks who really want, a perfect measure and do a study with 20 people because they know that they have perfect data on their 20 people. We approach this as we want to have data on thousands of people with the best measures you can scalably do in thousands of people, and develop then prediction models that can work well in large clinic populations where sometimes you may have incomplete data there as well. So we're in that trade-off between scalability and reaching lots of people. We have a little bit less precision in these decisions, but hopefully, because you have so many people, algorithms can be good at distinguishing the signal from the noise.
Thank you, Amy. There is a few follow-up questions that I would like to read. The first one is, how compliant are users of Fitbit in keeping them charged, for example, because we know these devices, just like everything else, including your cell phone, run on batteries and they need to be recharged. So do we have, I guess, either heuristic or some kind of evidence in terms of compliance?
I don't have data offhand in terms of the compliance. I will say this was a factor why we chose Fitbit specifically over Apple Watches, because for Fitbits, the charge lasts about 10 days. And it can be recharged after that in an hour or two. So for sleep in particular, it's much, you just get a lot more complete Fitbit data because people can wear it, up to 10 nights in a row without having to charge. Whereas Apple Watch, it's very common for people to do all their charging at night because it holds a charge for so much less time and has to be recharged for longer.
Perfect sense. 10 days is quite substantial, certainly
Yeah.
better than a cell phone. The next question comes from Betsy. She asks, are you testing any specific hypotheses with the introduction of genomics in your prompt trials?
At this point, we don't have a very specific hypothesis around the genomics piece, and that is, to be honest, the other PI's area of expertise more than mine. We are really interested, the genes for depression in particular, which is the focus of the new R01, are very complex. There's many genes involved. For some other studies, we've been using what are called polygenic risk scores to be able to take information across all of the, or many of the genes that have been identified as related to depression, and then be able to use that to classify people in ways that could actually probably be more meaningful for clinical care, because you're not trying to keep 30 different things in your head at the same time.
That makes sense. I hope you don't get overwhelmed with there was a flurry of questions here. The next one is another interesting questions. Are psychedelic treatments being looked into for research studies? Now, we all know very well that recently across the United States, including Michigan, various psychedelics are being to some extent legalized for recreational use. So this is quite a reasonable question to find out if anyone within Precision Health is looking into these things. And I'm not sure if Amy, you, or Rachel may be having some insights into that.
I can give at least a partial answer to that. I know that not a Precision Health study per se, but the Department of Anesthesiology just completed or just finalized a contract for doing a study on psychedelics and chronic pain, I think within the last week. And there's definitely a lot of interest and special interest group going on in that area. I don't know comprehensively all studies, but I definitely know of that one that I think is going to be a pretty landmark study.
Very well. Does anybody else on the team want to weigh in here with respect to psychedelics? Okay.
Yeah, I'll just say as well, there's a new center for psychedelics that was just started as well. It's a cross-campus center through which some of this work that Amy mentions is happening, including including aspects of consciousness and understanding consciousness.
Well, thank you, Chad. And we're going to come back to you shortly. The last question that I see in the Q&A is probably for Rachel. It asks, does PH still accept applicants?
Oh, I read that as accepting participants, and I wondered if it meant for the prompt study specifically.
Oh, for the prompt. Oh, maybe this was for a prompt. Yeah, okay.
Yeah, which we could answer it for maybe MGI as well, or some of the broader studies. But for prompt, yes, we're still actively recruiting, and still when people are at the point that they're scheduled for a mental health appointment, and we anticipate continuing to recruit, especially with the protocol of the NIMH trial going forward.
Excellent. Thank you. That's great, Dr. Bohnert. We are now going to take a 10-minute break. Unfortunately, Dennis McMichael, who was one of our participants that we wanted to feature, has lost power in his home, which was one of our concerns here, of course, at the leadership as well during these meetings. So he won't be able to join. So we are going to be taking a 10-minute short break for everybody to stretch, relax, take a sip of water, and then we will reconvene promptly at 3 minutes past 2 o'clock. So again, a short break for 10 minutes. We will restart with the remaining of our agenda at 2:03 p.m. Eastern Time. Thank you all very much.